Good morning, sir. How's it going?
Not good. I have a hard time getting a breath.
I see your oxygen's just a little low. When did this start? When did this?
About 15 minutes ago.
Okay.
I heard it.
Gotcha. You were in a car crash, is that right?
Yeah.
Okay. Let's take a listen to you. Deep breath in and out. You feel hard to breathe?
Yeah.
Let's give you a little more oxygen. Do you have any history of breathing problems at all? See if we can reposition you and help you out some. All right, sir. I'm going to give respiratory therapy a call, okay?
Okay,
Hey, this is Trump City Thomas. Just want to see if we can get respiratory therapy to come in. Thanks, appreciate it. All right, sir, they should be here pretty shortly.
Hey, I'm sitting out by the nurse's station. Call.
Hey, brother. Thanks for coming in. This fella, he's been hypoxic since I got on shift this morning. I bumped up him from 4 to 6 liters on nasal cannula. Thinking about going ahead and switching over to a mask.
I think that's a good idea. Let's try to see if we can get a little bit higher. Hey, sir, how you doing?
not good.
Just having some difficulty breathing. Can't take a big breath.
Yeah, I can't get a full breath.
Gonna put this on your face, sir, and still blowing. Take some good deep breaths in your nose, out your mouth.
Alright.
Does that feel any better? Just got a little bit. Doesn't look like he's concentrating much, really. Maybe we should give the doctor a call.
I think so at this point. Does he have any labs from that?
He has labs from this morning. We can also check on those.
Okay. Yeah, let's just take a look at his video. See
Yep.
what's going on.
All right.
You been coughing anything up, sir? Any kind of sputum, anything like that?
Hey, Dr.
Hey,
Thomas,
Doc.
I'm with anesthesiologist. How you
Thanks for
doing?
coming. Yeah, so this fellow was in a NBC this morning. He came in. He was standing in the low 80s when I first initially looked at him on 4 liters. I bumped him up to 6 liters, called RT, we put him on a non-breather. He hasn't gotten out of the 80s since, so we wanted someone to take a listen.
Yeah.
He sounds equal bilaterally, just kind of diminished and coarse. Okay. No significant history that he can remember.
Good morning, sir. Dr. Thomas, I'm one of the anesthesiologists. I'm just going to take a listen to you real quick. Do you have any history of lung problems?
Yeah.
Take some big deep breaths for me. Good. Again? Okay. Again? And one more. Good. Yeah. Do you have any medical problems?
No.
Okay, never had a heart attack or stroke, and you said no lung problems in the past, huh?
No.
Okay. I mean, I hear good bilateral breath sounds. There's just some wheezing.
I hear a lot.
I think maybe if this is just some developing pulmonary contusion or something like that.
He could take that too.
Yeah. Well, so, the problem we're talking about, sir, is you're not able to maintain your oxygen high enough. I think we are going to need to place a breathing tube for you, okay?
No.
All right, so what we're gonna have to do is induce general anesthesia, get you all the way off to sleep. We'll put that breathing tube in, and we'll keep you sedated so that you don't remember the breathing tube being in, okay? But we're gonna get ready to do that right now to keep you safe, okay? You're gonna do great. We're gonna take great care of you, okay? All right. So let's get all of our intubation equipment prepared. Let's get drugs for an RSI. When was the last time you ate or drank something, sir?
They gave me a crappy breakfast morning.
Okay, so maybe a couple hours ago.
Yeah.
Got it. Do you have any drug allergies? Got it. Okay. So let's get ketamine and rocuronium available for him. He's 80 kilograms, so since he's a little bit altered already, we'll do 80 milligrams of ketamine for induction. We'll follow that with 100 milligrams, which is 1.2 milligrams per kilogram for neuromuscular blocker.
80 milligrams of ketamine, 100 milligrams of rock.
I'm going to get an ambu bag and start pre-oxygenating while we're getting equipment ready. So just give me 1 second. We'll start with that. Sir, I'm going to take this mask off and replace it with a different one, okay? Pardon my reach here. Alrighty. Okay. Alright, so RT, let's go through our MS made mnemonic to make sure we have all of our available equipment. Okay, so in the first MS machine, I know we've got a ventilator available, but I want to confirm we've got a good functioning ambu bag with a PEEP valve and an oxygen source blowing at 15 liters a minute. Let's make sure it's all the way up. Okay, so we're just going to have you breathe this oxygen for a moment here, sir. So that's M. S is suction, so we definitely need to get some suction available with the Yang power. Looks like you're working on that. So machine suction. Next M is monitors. I see a rhythm strip. I see SpO2. I see non-invasive blood pressure. We'll get into the CO2, I'm assuming, afterwards as well. Yeah. Okay, good. A is airway. So, we've got potential concern for C-spine injury with a collar in place. Let's just do a primary glycoscope intubation.
Okay.
Since he's a normal sized adult male, we'll have an 8.0 endotracheal tube available. Gotcha. We use that primarily with some smaller sizes available if there's some bladder swelling or anything like that. For adjuncts, I want to make sure we have a nasopharyngeal airway and oropharyngeal airway of appropriate size. Make sure we have a bougie available, and then for emergency use, make sure we have our right kit on standby. Okay, so that's A. I is IVs. Hey, do we have a good IV access?
Good IV and metrodrome, sir.
Perfect. So we'll get free flowing IV going. We've got our meds, and that's our D. So drugs. So machine, suction, monitor, airway, IV, drugs. Once we've completed pre-oxygenation with 100% of VO2 for 3 minutes, we're going to do a rapid sequence induction. So we're going to give the full 1 milligram per kilogram, which is half dose. We're going to give the full 80 milligrams IV push, followed by 100 milligrams of rocuronium, and then flush that in with normal saline. We're going to let that set up, then we're going to do the glide scope intubation with our backups on standby. Okay. All right, sir. We're going to start getting you pretty sleepy here, so since 3 minutes lapse, we're going to go ahead and perform our rapid sequence induction.
Are you good with this position right now?
Yeah, we'll leave him pre-oxygenating like this. As soon as he's asleep, I will change positions just slightly, but this is good for now.
Okay, ketamine, yeah.
Ready? Please. We'll get you off to sleep here, okay, sir?
When you're ready for the rock.
I'm ready. Go for it. And then flush all of that. Sats are looking good. And I've got a grade 1 view. I'll take the endotracheal tube, please. Very good. Gently around the corner. Okay, go ahead and pull that salad out for me. Salad's out. Good. All right, so right at about 19, I'm seeing the cuff past the cords. I'm just going to go to 21 here. We'll go ahead and take the glide scope out. We'll inflate our cuff. Good. I'm going to hold into tracheal tube. It looks like our stats are still okay. So, nurse, if you go ahead and bag RT, we can leave the glide scope down if you just want to confirm bilateral breath sounds. So I've got color change times 1, now that's 2. So we'll give another couple of big deep breaths. That's good. We've got
belly first.
in-tidal CO2 color change times 3. We're going to listen.
Belly. And just give me 2 breaths.
Got it right there. Got it there. All right. So stats are good. So we'll keep ventilating. We'll squeeze that bag every 6 seconds. We'll get the ventilator ready in a second, but we'll just stay on the MC right now. Absolutely. All right. So we're in a good stable spot. We're just going to go ahead and review. You've got propofol online.
Yes,
we can start it at maybe 20 mics per kilo per minute for long-term sedation because he is paralyzed. We're going to secure this ET tube. Other things that we should consider afterwards, obviously we want to confirm placement with chest x-ray, but it looks like we're in a good spot. I would advocate for use of an orogastric tube, and then we can place a Foley to start with. We can place a Foley afterwards once we ensure that the sedation is on board, okay?
X-ray, OG, Foley.
Got it. And long-term sedation.
And long-term sedation.
Yep. Got it? Of course. Still looking good on the monitor. Normal, well, relatively normal. That's sats are good. All right.
Thanks, sir.
All right, team. Looks like we're in a good spot. Let's talk about vent settings while we're here. So he's 80 kilograms. He looks like he's pretty close to his ideal body weight. You know, if we're doing lung protective ventilation, let's say 6 cc's per kilo of ideal body weight. So you can start at a tidal volume of 480 there. We'll do a respiratory rate of 14, a PEEP of 7, and an FiO2 of 50%, and we'll just go from there. We'll see how he does. Good. All right, I got to get back to the OR. You guys good?
Cheers, sir.
Very nice work, guys. Appreciate it.
Yep.
Thank you, guys.
Mm-hmm.
All right, sedation's infusing. We'll call for an X-ray.
ABG 20 minutes. OGAG 4 weeks. That's pretty much it.
We'll get working on that stuff.